Good afternoon, everyone. Hope you're well, and thank you for joining today's webinar session as presented by London Bridge Hospital. My name is Kamal, I'm the Relationship Manager at HCA Healthcare UK, and I'm delighted to introduce today's speakers, Mr. Jonathan Noel and Matthew Boltishid, who will be providing a urology update. Mr. Noel is a consultant urological and robotic prostate surgeon at Guy's St Thomas's Hospital, as well as the lead in prostate cancer diagnosis at Lewisham and Greenwich NHS Trust for the South East London Cancer Network. And as you can imagine, he specialises in prostate cancer. And then Mr. Boltishid is a consultant urological surgeon at Guy's St Thomas's as well, and he specialises in stone diseases. He's one of the leading kidney stone surgeons in the UK. Privately, both our consultants today work at London Bridge Hospital. And if you have any questions or would like to know on how to refer your patients, feel free to get in touch. We're more than happy to provide details. And for further information, you can also visit our website, which is hcahealthcare.co.uk. So before I pass it over to Mr. Noel, who'll be starting the session off, we have a couple of housekeeping points. As you all can see, this session is being recorded and will be shared with you following the webinar along with your certificate. And you also have the opportunity to ask questions throughout the talk. Simply type in your questions through on the chat function, and we'll simply ask them out during the Q&A session at the end. But without further ado, I'll pass over to you, Mr. Noel.
Okay, thank you. You can share the slides, please. So thank you for the introduction and thanks for having me. So I'm Jonathan Noel. I work at Guy's and at HCA London Bridge. And I'm just going to give you a whistle-stop tour to the prostate, and we're going to be touching on a benign prostate enlargement as well as prostate cancer. Next slide. And just a brief outline on screening guidelines internationally, the diagnoses or the pathway that we offer patients with suspicion of prostate cancer, but also with symptoms related to benign prostate enlargement and the management options as well. Next slide, please. So we all know what PSA stands for, prostate-specific antigen. We know that it can be elevated in normal circumstances where the gland is just large, but also in cancerous conditions of the prostate gland. It increases with the size of the gland, and we have to be aware of that, but also age and the coexistence of a tumor can sometimes make this a tricky thing to actually get right and get the diagnosis appropriate as well as a management. But the conditions that cause it to be elevated, we know, are inflammation, so an infection, UTI, it's important to rule that out. But also be aware that a large prostate can also give you a reading that is above the normal for the reference range for age. It's important that when you talk to your patients about PSA testing, that they would have done a few things to make sure that they get the reading that is truly reflective of their steady state, such as no intercourse, vigorous exercise leading up to the blood tests. If they've had a recent urinary tract infection, that's a no-no, get over that, and then do the PSA a few weeks after. Next slide, please. And it's all in the media. We know prostate cancer is common in men, the second most common cause of cancer death after lung in men. And the risk factors are there. And we can see that 1 in 8 overall for men, but 1 in 4 for high-risk groups such as Black patients, and also first-degree relatives. The incidence rate seems to be increasing, and that may be down to awareness and people coming forward, but we are seeing a rise in the incidence of prostate cancer cases. Next slide. So the European Association of Urology, a real large body that we look to for guidelines and recommendations, have put a number of recommendations with regards to PSA testing that you can see in the third row, that we offer PSA testing to a well-informed patient. And they say from 50 or 45 if there's a family history, 45 if they're from African descent, or they have a BRCA2 mutations in the family, or they've had gone forward for genetic testing, then they say younger as well, and that's strong evidence. Next slide, please. Interestingly, just under 2 years ago, the European Commission published an up-to-date EU screening recommendation for all cancers, and for the first time they included prostate cancer. And that's really kind of shake the foundations of the urology world, because prostate cancer screening is contentious. Next slide. nice guidance in the UK as of June 2024 still do not advocate for screening, but they do advocate that men should be counseled on the benefits and harms of whether a PSA blood test should be undertaken. These conversations sometimes are hard to squeeze into a quick consultation. I understand that, but we have valid concerns of overdiagnosis and overtreatment, and I'll show you how in 2024 we are getting around that. But certainly the pandemic made patients very reluctant to approach secondary care or even primary care. And we're seeing in our Southeast London network a reflective point in that there's more patients presenting with high-risk disease as a result of not going forward to you in primary care. Next slide. But to go back to benign prostate hyperplasia, you can see that the growth of the prostate can occur with some bothersome symptoms. It's important that you have to rule out a urinary tract infection. That's not normal in a man because of the extent of how long our urethra is compared to female counterparts. But also, if one comes to you with urinary tract symptoms, not only should you investigate them, but address what they consume. I think it's taken very lightly that patients may have excess caffeine intake, such as coffee, tea, Coca-Cola. These drinks will really irritate the bladder and cause an overactivity, a surge, and a urinary tract symptom complex can occur. Usually we call that the irritative symptoms or the fun symptoms: frequency, urgency, nocturia. And you can do your part by counseling on decreasing caffeine intake, spicy food, smoking, alcohol. These things will really irritate the bladder. But nonetheless, you should refer to urology if this particularly coupled with hematuria, or you're just not getting over their symptoms with conservative measures. Next slide. So the prostate changes, as we know, it can become normal enlarged, but also can become inflamed. They usually get this irritation when they pass urine, but also, as I've bolded, there's a real complex of ejaculatory disturbances. So that's prostatitis may be something to entertain as a diagnosis. Usually my management for that, it would be to find the culprit through urine or ejaculatory fluid cultures and curtail antibiotic treatment according to that. We'll also be aware that there can be other conditions that coexist with prostatitis. And if you're not getting over it with antibiotic therapy, then it's better to refer on. But the prostate can change and become enlarged and narrow the water pipe, as you can see in these lovely diagrams that I have to give credit to online artists for. Next slide. This is sorry, just click one back. This is an MRI scan of a prostate that you can see is enlarged on the top right of the screen. It's the bladder, and the median lobe of the prostate or the middle lobe is projecting into that bladder. So there's no way that that man is going to relax his bladder neck and empty efficiently. And you can throw all the medication you want at them: tamsulosin, which relaxes the bladder neck; finasteride, which can decrease the size of the prostate over time. But eventually that prostate will need a procedure, need to be addressed. Next slide. Stay there. Making a decision about an enlarged prostate is tricky. I think in the NHS has really come up with a lovely support tool because it's almost like shopping for milk now. There's just so many different types of milk. There's oat milk, semi-skimmed, you name it. The same for BPH or enlarged prostate treatment, and it gets tricky. But I think the medicines are a starting point, but surgical decisions are challenging and really extend the length of consultation that we have with patients now. But this could be something that could help you and your patients in primary care perhaps focus their conversation on what they want to explore. Next slide. And as you see, this is just kind of a snapshot of what you could do on the right of the screen, which is conservative measures and medical therapy. And on the left of the screen is where you can see surgical therapies. So RESM, PAE, aquablation, Urolift, HoLEP, TURP, some of the things we offer at Guy's Hospital and at HCA London Bridge. And they all have their benefits and they all have their specific gland sizes. And I don't want to take up the whole time of discussing them, but I will just go through some broad strokes. Next slide. Aquablation is new. It's a water-based therapy, but we do use coagulation and energy to stop bleeding. It's good for small and large prostate glands. So that's, I think, the benefit of it, is that it can be used. The large prostate, we are actually running a trial of prostate sizes up to 180 grams, so very large prostates, where the laser therapy was the winner for this. We're seeing that aquablation can be offered. There is a bleeding risk, as I've mentioned, but we take our time with coagulation. There's a higher chance with this therapy that there's a preservation of ejaculatory function, if that is important to that man. But it has to be said that less tissue is removed compared to a laser debulking. And also there is no histology from that tissue for analysis. We usually say it's a general anesthetic procedure, but it is new, and 5-year data is encouraging compared to the traditional TURP, and it is on offer. And we do it at Guy's Hospital as well as HCA London Bridge. Next slide. HOLEP, it has lots of data behind it. It debulks very large prostates. There's less bleeding. You can get home probably a day earlier. But aquablation is actually shown to have day case applicability. So as HOLEP can be a day case procedure as well, but it does remove more tissue. But the ejaculatory function is very likely to be gone after a HOLEP, so it's important patients are aware of that. And this is a conversation that probably would be steered with us, but it opens the door to conversation for younger patients who you may see with benign enlargement. Next slide. So going back to an elevated PSA, maybe due to a large gland, but maybe due to something else. You're worried about overdiagnosis and overtreatment, and that would have been started with your PSA testing counseling. But believe me, we see patients and we MRI everybody. We think that MRI is a tool that will help us to determine if there are any areas of concern to biopsy. And if the MRI is normal, we do not biopsy patients. Almost 1 in 4 patients will have a normal MRI and we don't ever touch them with a needle. The Promise and Precision trial are UK-led trials which have shown that we can be more precise with our biopsy strategy with an MRI, and we can pick up significant cancer and leave behind the insignificant cancer. So I think MRI is here to stay, and it allows us to be more specific and targeted. Next slide. Transrectal biopsies, again, historically, when you refer to urologists for elevated PSA, you worry that a transrectal biopsy would happen, an infection may occur, and rehospitalization, and sometimes morbidity will occur as well. I think quite severe. There has been a fluoroquinolone resistant bacteria in the rectal flora, so putting needles and traversing it through the rectum to take a biopsy sample of the prostate was met with a lot of infection, and to get around that, Southeast London led the introduction of, next slide, the transperineal approach. So we have transrectal exited from our biopsy strategy. We've trexited. We've done a transperineal biopsy approach where the probe of an ultrasound still goes in the rectum, but the needle goes to the skin of the perineum, which is below the scrotum and the rectum. And there's less risk of infection. We can do it as an outpatient. We can get better sampling of the anterior segment of the prostate, which traditionally was very challenging to get if it was done transrectally. And if the patient's fit and healthy with minimal comorbidities, it's been shown in randomized studies that we do not need to give antibiotics, and there is no risk or harm to these patients who are fit and well. Of course, if there's a diabetic patient or a catheterized patient, we would be giving antibiotics. That's appropriate. But I think transperineal is a real forward-thinking antibiotic stewardship way of making sure we don't promote further antibiotic resistance. Next slide. Active surveillance. So if you do pick up prostate cancer and it's low risk, Gleason 3+3. This diagram shows you the different Gleason stages under the microscope. If it's a 3+3, then we would really advocate active surveillance and not treatment. We all know that the two numbers 3+3 or 4+3 are numbers assigned by the pathologist. The first number is usually the changes that are more populous in the microscopic slide. So if it's a 4+3, I'm seeing a lot of 4 and a little bit of 3. Same if I see a 3+4, I'm seeing a lot of 3 and a little bit of 4. So active surveillance is good for Gleason 3+3 and also 3+4. We do MRI scans and repeat biopsies only if necessary, and there's good evidence, next slide, of survival, and that's been shown in many studies. And I think it really addresses the overtreatment question from primary care. Surveillance is here to stay. A watchful waiting is a less aggressive system. I think some patients may not be very fit, and if they have undergone a biopsy for one reason or another, then we would advocate not to put them through MRI scans and repeat biopsies, but also just kind of take a more conservative approach depending on their comorbidities and their performance status. But uptake of active surveillance in the UK, 95%. US, other countries, lower, and there may be different reasons for that, but I think active surveillance is very acceptable, and it shows that we really know how to adapt risk profiles for patients now. Next slide. And that's just some evidence from big centers in the US that looked at the risk of distant metastases or death in thousands of men, and it was less than 1% on active surveillance. Next slide. So reducing side effects of radical treatment, obviously robotic prostatectomy and radiotherapy are the mainstays of radical treatment. If patients have Gleason 7 with lots of Gleason 7 and above, we would recommend either of these two treatments, standard of care anywhere. And robotic prostatectomy is something that is on offer. Obviously, we lead it at Guy's for the South East London network, and also at London Bridge, we offer it as well, where they're the highest volume private hospital doing robotic prostatectomy. Same day discharge is possible, although recovery time and different circumstances mean that we usually keep you in for one night. Functional recovery, we're getting better. We have data to prove that, and that's been collected by independent specialists, not surgeons, because if a surgeon collects it, there may be some element of bias. We accept that. But I think the continence in less than 3 months to recovery or having one pad is something that we would recognize as being the norm now. So there's no longer incontinence for ages with lots of leaky pads. That would be abnormal, and if that's the case, we would get a continence specialist to get input and help that patient. Radiotherapy, you can see hydrogels are important to make sure the rectum isn't involved when the radiotherapy is given externally. We've given different regimens. We manage a large gland before radiotherapy because we know that's important as well. Next slide, please. So this picture is just to show a robot, top left, that's where one sits down and then operates the arms, which are 4 arms here, and that's a multi-port robotic system. And on the right, HCA London Bridge recently acquired a single port system where it's 1 port and deploys 4 arms. So 1 little incision on the tummy versus 4 to 6 with the other. I think when you measure them all up, it's probably the same length, but some patients may prefer a single port option. A little study that I did when I was a fellow in Florida looked at patient satisfaction of a single or a multi-port robotic prostatectomy. No difference, they still went back to their normal activity, but it is an option for patients, particularly if they've had lots of surgery on their tummy before, and it should be discussed with the surgeon. Next slide. So if you go to the next slide again, please. It's a little video, so hopefully it comes up, but it's just so you can appreciate that we sit down and we're very active doing robotic prostatectomy. I don't turn on the machine and go and have a coffee. which some patients are afraid of. It's totally under our control. It's not autonomous, and we try to spare those nerves, which is represented by that diagram as the yellow spaghetti. We spare them, but there is an intensive regimen to get erections enough for intercourse. And we're very frank with patients as to what their potential for potency recovery should be. Next slide. There's this old data on open radical prostatectomy versus robotic prostatectomy. There's been shown to be no difference. I think this argument is out the window. Robotics is here to stay because there's less blood loss and patients can get back to work faster. This paper showed no difference, but this paper showed an open surgeon who was about 20, 30 years experience versus a younger colleague who had just done robotics, and their outcomes were the same. So that means a robot is an equalizer. It means you can get as good as someone with lots of years of experience, and hopefully over time we'll just keep improving. Next slide. Yeah, over here you can see that the Brazilian cohort did a comparison of open versus robotic prostatectomy. So this is contemporary series, 4 different surgeons, and robotic surgery had shown superior potency and urinary continence recovery compared to open surgery. So if your patients are interested and they don't have robotic surgery, where they come from, then I think it's something to explore here in the UK, where we have a lot of systems and a lot of experienced surgeons. Next slide. And I don't think I can leave this discussion on prostate cancer without mentioning focal therapy. It's the new modality. It's becoming very popular. It's not offered everywhere, and it certainly isn't standard of care currently. I think its applicability can be for intermediate prostate cancer. It's being sought after because it has less impact on your potency and continence. Sorry about the spelling error there. And I think, it has to be said that it's not for everyone. It's for a small little lesion within the prostate. And this recurrence rate is 1 in 3. I am of the opinion that very young patients should be very wary of this modality, because if it's going to come back again, it could come back with a higher grade prostate cancer, and then you may be looking at very radical surgery where nerve sparing is no longer possible. It's something that you probably will be asked by your patients, not standard of care, not for everyone, worth discussing with a specialist who does focal therapy. Next slide. That's a little table from the Imperial College group, who have a lot of experience in focal therapy. And because it's from them, obviously it's going to be very pro focal therapy. But the salvage rate, which is the second from the bottom, salvage at 5 to 10 years, is slightly higher with the focal therapy. So patients need to be aware that the recurrence rate is higher. And at the end of the day, if the primary focus is to treat prostate cancer, then our opinion would be to treat radically. But focal therapy can be discussed and should be discussed. Next slide. Coming to the end here, I think the PROTECT study is something to really hone in on. The group from Oxford did a lovely randomized trial with 3 different groups: patients who underwent watchful waiting or surveillance, surgery or radiotherapy, and they found that survival was high irrespective, and their risk stratifications back then were unreliable. And they said the long survival in the PROTECT group means that population-wide testing should not be indicated. Next slide. And you can see that metastases on the right of the screen was lower with metastases-free survival, was lower with patients who underwent monitoring versus treatment. So if they want to be monitored, patients can be, but there's a higher risk of metastases, although not death. Next slide. But my thoughts are, this study, although it's great, randomized controlled trials are hard to do, particularly with surgery. Majority of patients were of low-risk prostate cancer, 2% high-risk prostate cancer. Ethnicity data, 97% white men. In Southeast London, we at Guy's Hospital probably have about 50% of patients from African ancestry. having prostate cancer. So, the applicability of this study to our local condition scenario and population may not be applicable. And in 2024, we have MRIs, we have staging PET scans, we have robotics. This was not the case during the time of the PROTECT study, but it's still an important study nonetheless. Next slide. You can skip that slide. Next slide, please. So just to summarize and end, thanks for listening. I think early prostate cancer, it's asymptomatic. Screening is important to be discussed. MRI scans, an amazing tool that can avoid unnecessary biopsies. 1 in 4 men will be reassured that they don't need a biopsy, and we'll send them back to primary care. And transperineal biopsies, really lower the risk of infection. And I think the risks of treatment of radical prostatectomy, radiotherapy are being mitigated by different strategies, and there is less overtreatment. So I think we have to have transparency of our outcomes and keep publishing as per National Prostate Cancer Audit. Next slide. And if there's any questions after this meeting, that's my contact details and that's my QR code. So thanks for listening.
Thank you, Jonathan, for that. What's the stop for prostate cancer? Really helpful there. As mentioned, if there's any questions for Jonathan regarding prostate cancer, feel free to put them in the chat and we'll cover them at the end. So next we have Matthew Bultitude. Did you want to share your slides, Mr. Bultitude? Perfect. Thank you.
Right, good afternoon. Thank you very much for the introduction and giving me the opportunity to talk to you about something I spend most of my time doing, which is dealing with kidney stones. So I'm a urologist at Guy's and St Thomas's, as you heard. I was previously the lead for the stone unit. I'm now got a bigger management role as clinical director for transplantation, nephrology and urology. So I spend half my time doing that. And I work at London Bridge Hospital, as you heard, and I'll talk a little bit about this at the end, but I'm lead there for lithotripsy. We've got a lithotripsy there in the last 18 months, and that's the only one of 2 private lithotripsies in London. So, and this slide, actually, this isn't my picture, I found this on the web, but it just shows how beautiful kidney stones can be, although I'm not sure any patients think that kidney stones are beautiful, do they? So, let me just advance the slide. These are my disclosures. And so just by way of introduction, stones are definitely not a new problem. And if you look back in history, 3 of the earliest known elective operations were, well, 2 urology ones: circumcision, trephination of the skull, so burr holes, and cutting for stone. And the oldest known stone dates back to nearly 5000 BC, which was in a 16-year-old boy in Egypt, and that was a pure uric acid stone. But unfortunately, that specimen was destroyed in World War II. And of course, all of us take the Hippocratic Oath, or a version of the Hippocratic Oath, don't we, these days? And Hippocrates knew something about this as well, and said, "I will not covet persons labouring under the stone, but will leave this to be done by specialists," because it was recognised back then that stones should be treated by specialists, as of course they should do now. So what am I going to cover in this talk? Well, I'm not going to tell you about symptoms of stones. I think we learned that all in medical school, and I think you know that, the sort of classical symptoms, but also it doesn't always have to be like that. What type of analgesia to give? I'll mention that briefly, but I think that's pretty straightforward. Not too much about sepsis and stones, because that's mainly in-hospital treatment, or how amazing our surgery is, or indeed how wonderful my surgical videos are. So what I thought I would try and cover in the next probably 15 minutes is look at incidence etiology, the risk of recurrence, thoughts about imaging, chance of passage, which is a common question that patients ask. Who needs metabolic testing? What dietary advice should we be giving our patients? And then just touch on some recent NICE and GIRFT guidance on kidney stones, which does seem relevant to anyone seeing patients with kidney stones in the UK. So what's the incidence of stones? Well, broadly, I tell patients that in men it's about 10%, and women it's now about 6%. But the risk is increasing, and that gender gap is narrowing all the time. Between the stones are increasingly common, and between 2010 and 2015 there was nearly a 5% increase in stone disease. but I accept that with different changes in the way NHS codes things, there could be other reasons for this. And there's a slightly smaller rise seen between 2015 and 2020. If you use that data, that gives an annual prevalence of 0.14%, but a lifetime prevalence in England, this is English data, of 12%, so actually higher than that 10% just for men that I quoted you there. Interestingly, it's static in those of working age, but quite a significant increase in those patients over 60, which may be because people are living longer and there's more of them. It may be due to increasing obesity, of course, and we're keeping people alive longer with all sorts of different treatments. In that time period, there's also lithotripsy has been reducing in the amount of its usage, although I think we will see that sort of stabilize a little bit, and I think COVID has focused our minds that not every patient needs intervention or invasive intervention. And ureteroscopy has continued to go up and up, which I think reflects much better technology that we have now and ability to treat these stones, but also the fact that surgeons like operating and we like doing ureteroscopy. Now, I think this is important. This will come up, I imagine, all the time for you in your patients, and that's the incidental stone. So you have a scan for something else and it shows a stone. So how common is that? And I quote this study to a lot of patients because a lot of these get referred to me, and it's always difficult to know how to advise a patient who's never known there was a problem there before. These stones could have been there for a long time, you just don't know, and of course we can't predict the future. But when you look at bowel screening studies, and as you can see, this is a study of over 5,000 patients, the incidence of, asymptomatic urolithiasis, the incidence of asymptomatic stones was nearly 8%. So 100 people off the street right now, 8% will have stones, they never knew about it. So it's a very, very common problem. And as I said, not everybody needs treatment, but everybody does need to know there's a problem there, and they need to know what their options are, because stones, pain and colic never ever occurs at a good time. There's never a good moment to go, oh, I'll have colic today. Oh, that's nice. It always happens when you're busy with work, busy with family, going on holiday, etc. So patients at least need to know there was a risk there. And this study then looked at what happened, because of course the natural history is important here. And 10-year follow-up, this is an American study that had the data for that, 20% of those patients would have a symptomatic episode, which could mean some pain and it goes. It doesn't necessarily mean intervention. But that's quite useful to be able to counsel patients and tell them the risks they have going forwards. And of course, there's a big difference between the stone shown on the left there in box A, which is quite a big stone. I would definitely offer treatment for that, versus here, and the one on the right, which is lots of tiny little stones, all about 2 millimeters, but also most likely to pass if they were to move. So why do people get stones? Well, the fundamental reason is supersaturation of the urine, and of course there are a lot of causes for that, of which I've given a bit of a list here. Geographical is an important one. It's an important one with global warming, and this picture is actually a little bit old now, so I think it does need updating, but I can't find an updated version of this. But this shows the concept of stone belts, where there's an increased, even higher risk of stones due to heat. And you can see it sort of covers a good swathe across southern Europe, the Middle East, into the Far East and Australia, and then also across Southern America. But those stone belts are widening and increasingly coming sort of more into Northern Europe, where they put that in amber, haven't they? So I think we're going to see that is increasing with global warming. Dehydration is a very, very common cause of stones, and we'll talk a bit later about dietary advice. But we tell patients they should make 2 liters of urine per day, and studies have clearly shown that. And that is actually quite hard to do. And that's why I put occupational here, because often there are occupational reasons why people struggle to drink much. If you work in a kitchen, if you work as a taxi driver, a bus driver, you just can't have a bottle of water on your desk and drink it all the time. There's obviously medical disorders, hyperparathyroidism, diabetes, etc., and we'll talk about that. Anyone with any kind of diarrheal syndrome, whether that's from surgery, whether that's from Crohn's disease, ulcerative colitis, are at increased risk of stone disease and metabolic syndrome, which I'm going to talk about here. So here are the 4 facets of a metabolic syndrome: obesity, diabetes, hypertension, and dyslipidemia. And all 4 have been shown independently to be associated with increased risk of kidney stone formation. So no wonder the metabolic syndrome is of interest in terms of kidney stone disease, but also important to address if we're going to try and reduce the risk for patients of of forming kidney stones. And the reasons, I won't read all the slide out because I put some of the mechanisms as to why people get stones for these reasons. But it stands to reason, and we know stones increase in obesity. The bigger we are, there's more turnover of nutrients and the more acidic urine we have. Diabetes and insulin resistance leads to a reduction in urinary pH, which increases the risk of calcium oxalate and uric acid stones. Hypertension is a little bit more tricky to understand. It definitely, studies which just have a higher risk of stones, and also the other way around, that stone formers have a higher risk of hypertension, which could be due to insults to the kidney previously and intervention, and also dyslipidemia. And this graph here, just on the left, just shows the risk of stones with increasing obesity. And of course, overweight isn't that uncommon anymore. Most people are more than BMI over 25, haven't they? So overweight increases you just to a 1.3 fold risk increase, and obesity a 50% increase in the risk of stones. And the graph on the right is just simply showing that we're getting fatter as a population. And so that probably explains why stones are increasingly common. So what imaging to do? I'm not going to show more than this slide. I mean, obviously we know we can do X-ray, which it's actually fairly poor for kidney stones. It's quite useful for us to survey stones. If you've got a kidney stone that's 5 millimeters, and you can see it on X-ray, you could do an X-ray in a year or two and see if it's grown. It's quite helpful in that. But it's not a great test if you've got someone presenting with abdominal pain, because a lot of stones aren't seen, or are too small to be seen, or aren't seen. Uric acid stones are radiolucent, so they would never be seen. And actually, I think digital X-rays these days are not as good as the old-fashioned X-rays in terms of showing stone. Ultrasound is a great screening tool. It's cheap, it's available, it doesn't involve radiation. And there are trials that suggest that should be done in all patients first line. But actually in that trial, a lot of patients go on to have CT scan anyway. So it's more of a guide, and some patients attending A&E will get a fast abdominal ultrasound just to see. And we should be thinking about that particularly in young women, where actually the diagnosis is more likely to be something else other than stone disease. But the main imaging choice is a non-contrast CT scan. This has nearly 100% sensitivity and specificity for ureteric stones. And so this is what you get if you go into, I think, almost any emergency department now in the UK. You certainly do in all the hospitals around us in southeast London. And the images I've just shown on the right, so the top image just shows the right kidney with some stranding around it. See, the CT shows that nicely. So we know there's something going on, that there's been an insult to that kidney. There's probably a little bit of fluid extravasated outside. And in the bottom image, you can see there's a stone just near the bladder. So this is a small distal ureteric stone causing right-sided ureteric colic. So the patients then want to know, what's the chance of passing? And you can stratify that either by stone size, as you can see, or by stone location. So of course, it stands to reason that a small stone in the distal ureter has got a very high chance of passing. A big stone in the upper ureter has got a much less chance. And actually 6 millimeters is quite a useful cutoff, and stones over 6 millimeters are far less likely to pass. But overall, large studies have shown us that actually 80% of all comers stones will pass spontaneously. And so patients can be reassured about that. But big stones, particularly in the upper ureter, should probably have primary treatment, and probably shouldn't wait around for a month waiting to see if it'll pass. So if I saw someone with a 6 to 8 millimeter stone in the upper ureter, I would advise primary treatment and not just surveillance with repeat imaging. What treatments do we do? Again, not too much on this. It's important always to say that sepsis is an emergency. A blocked infected kidney requires urgent drainage, which is with a stent or nephrostomy, and that's a classic urology debate, and it can be either. It really depends on local availability and choice. And then in terms of treatment, shockwave lithotripsy in this country is done under local anaesthetic. It's not the case in other countries. So it is very easy to do. Patients walk in, have some anti-inflammatory medication. We don't normally ever really give sedation anymore, have their treatment, and then can walk off afterwards. That's what makes it so attractive. And actually our own data here at Guy's, but also backed up by other units, shows that if you have shockwave lithotripsy for ureteric stones, and you have to be able to see it to target it, so it's got to be visible on an X-ray to be able to target it. But if you can target it, you've got an 80% chance of that stone being cleared with shockwave lithotripsy. So very high success rates for lithotripsy. Ureteroscopy, I mentioned, increasingly common because our instruments are getting smaller and more nimble. This is just a schematic of a flexible ureteroscope and then a basket and a laser. But you can access stones in all parts of the kidney, and so usually in one procedure you can render a patient with several stones in the kidney stone free. For larger stones, PCNL, that's been around for 30 to 40 years, so a direct puncture into the kidney. Traditionally, it was with a hole that was between 8 and 10 millimeters in size, but that's getting much more miniaturized now. And the bottom picture there just shows the comparison between a standard size PCNL, which we still do for very big stones, for staghorn stones, and that's an ultra mini PCNL size is the one at the bottom there, which is 11. That's 11 French, I think. So you can see how much smaller instrumentation has become. And then there is the best of both worlds, and this is increasingly common, and we do quite a lot of this at Guy's, which is a combination of PCNL and ureteroscopy at the same time. So patients are supine, and you just access the kidney through the side, access percutaneously, access the kidney via the bladder with the ureteroscope, and then you can take out big chunks of stone with the nephroscope, and you can access using the flexible ureteroscope the bits that the PCNL tract can't get. And so that gives you your highest chance of being stone-free for people with complicated stone disease. So next question, who should have metabolic evaluation? Well, in some ways, the answer is everyone. So any stone formers should have a stone analysis sent if it's available. So if patients do have colic, they should be advised to try and collect it, and we'll send it off if that's the situation. But often patients do pass things and don't notice it. Every patient should have a urine pH measurement, and every patient should have at least a serum calcium. And actually the guidance says urate as well. And it's said that 1% of patients presenting with stones have hyperparathyroidism. I can't believe that figure is true, and it's got to be less than that. But actually, you don't want to miss somebody with hyperparathyroidism, and you don't realise until their third or fourth stone episode that that's what the underlying cause is. And that obviously can be simply diagnosed initially by sending a calcium level. And then patients who are higher risk, so that's patients with recurrent, highly recurrent stones, if they're particularly young, which the European guidance classifies as under 30 years of age, or bilateral stones, should also do a 24-hour urine collection for all the parameters that I've shown there. And these are some of the things we're looking at within all these tests. I just mentioned hyperparathyroidism. We're looking to exclude renal tubular acidosis. Full-blown RTA will usually present as a child, but actually incomplete distal renal tubular acidosis isn't that uncommon. And you can get a suspicion of that from urinary pH measurement. And you can measure then the serum bicarbonate to then see if that's on the low side, which might suggest that. And I think if that's the case, then they need a nephrology opinion. And you'd want to check their urine for citrate to see if they've got hypocitraturia, which you would get in a renal tubular acidosis. And then, of course, we're checking the urine for hypercalciuria, which can be managed with a lot of water to dilute it, a low salt diet, because salt, sodium and calcium it's a co-transporter in the kidney. So if you reduce your salt, you reduce your calcium coming out in the urine. Hyperoxaluria, so oxalate, which is primarily managed with low oxalate diet, unless you've got very high levels, in which case you need to be in a nephrology clinic. Urate, and of course rare causes such as cystinuria, which we have a lot of at Guy's. We've got the biggest clinic in the world in cystinuria, which is a rare genetic form of kidney stones. So what to advise on diet? Well, I could probably do a whole talk on this, and I've condensed it into one slide. So these are take-home messages that I sort of spell out to patients. Lifestyle measures, so losing weight, achieving a normal weight for the reasons I've already shown, and which means, of course, a healthy diet, and drinking lots of fluid with the aim of producing 2 litres of urine per day. And that can be quite difficult to do. If you go to the gym, you've got to replace those losses in hot weather. If you work in the kitchen, you've got to replace those losses, etc., etc. A strict low salt diet, the lower the better. There's not much good that comes out of high salt diet. A low fat diet. I say sensible amounts of animal protein. We know that animal protein increases your risk of stones, particularly red meat. So if you have a lot of red meat, try and cut back on it. I tell patients to try and have a vegetarian day or two. Something fun to do at home, but also just, it's all about healthy eating, isn't it? The paradox is that you shouldn't reduce your calcium, because most patients need a normal calcium intake. And actually, paradoxically, if you reduce your calcium, calcium binds to oxalate in the gut when it's ingested. And if you have a low calcium diet, the oxalate is free in the gut and can be preferentially absorbed, which then goes around the body and then can crystallize to form calcium oxalate stones. So you shouldn't cut back on dairy unless you're particularly advised to, because your calcium intake is too high. High fiber intake is good for stone prevention. And you can limit oxalate-rich foods, but that's really only for calcium oxalate stone formers and probably very recurrent stone formers, because a lot of foods that are, you can download these lists off the internet, that are high in oxalate are actually also very healthy for you. Strawberries, raspberries, spinach, etc. and limit purine intake if you're a uric acid stone former. And I just put some examples. If we were in person, I'd do a little quiz, go healthy or non-healthy. So water with lemons is healthy. Lemons, you get the benefit of the citrate, which alkalizes the urine and increases citrate in the urine. Beer, that's always a controversial one. People go, oh, when I've had colic, I just drink a beer or two and it flushes it out. And of course, volume is important, and maybe a beer relaxes you. But in general, beer, of course, is not a healthy drink for stones. And then in terms of carbonated drinks, I mean, some of the advice says avoid carbonated drinks, but if you're going to choose one, Sprite Zero would be a much better choice than Diet Coke because of the way that it's phosphorylated. Patients ask about what type of water, and this is a short article I wrote some time ago about this, which is actually very well downloaded and read, I think, because patients find it and read it. Hard water increase your risk. Hard water is important. It does increase the urinary calcium, but it also increases citrate. And when people looked at cohort studies between hard water and soft water areas, they found no difference in stone formation. And actually, for the reasons I've said, that you actually need to have a normal calcium intake, maybe some patients need that calcium that comes in hard water anyway. So I think it's, so I tell patients that obviously it's an individual choice. I don't particularly think that you need to buy a water softener for home or spend a lot of money on bottled water unless you particularly like that. And just be careful with the bottled water, because actually they can be quite high in sodium. And alkali water, which is very trendy in America, and I think it's probably slowly coming here and advertised as being super healthy because it's alkali, has no free cations, so it doesn't have any alkalization effect on the urine. So it is a complete misnomer and does not affect the urinary pH, and therefore doesn't affect your stone formation, other than the fact that you're drinking water. Risk of recurrence, I tell patients that actually, if you're truly stone free on a CT scan, I reckon you've probably got a 20% chance over 5 years. Historically, we used to, the sort of old adage was 50% over 5 years, 70% over 10 years. But that was really based on old IVUs, and you didn't really know, maybe they had other stones already. But if you're truly stone, you've had one stone, you're truly stone free, then actually your risk is probably a lot lower than that. Although 20% is still 20%, isn't it? It's still quite high. And you can reduce that significantly by just maintaining that 2 litres of urine output per day. And then I said I'd finish with just a little bit on this. So the NICE guidance on kidney stones, which was 2019, and the subsequent GIRFT report. And the reason for this is because actually there is huge variation in practice across the UK, and it's very surprising. Even in terms of getting a CT scan, is hugely variable. In terms of getting anti-inflammatory medication, is the primary analgesia is very variable. And I just put this graph, which is a GIRFT graph, just to say, I don't think you can see me pointing, can you? But depends on where you live as to whether you get a stent put in if you're admitted, from almost 0% up to 60%. The chance of getting a primary ureteroscopy, so if you go in with a stone and it's not going to pass, can be 0% up to 40%. So why is that variation in the country, and how do we try to improve that? So this is the NICE guidance, which I've just put the headlines here, but the yellow ones are actually, I think, relevant. So diagnostic imaging, it says get a CT scan within 24 hours. So actually, that's clearly important that providers do that, but it's possibly taken diagnosis out of the realm of general practice. And I wrote an article for the BMJ about 10 years ago with a GP about how GPs could manage colic, but you do have to have access to imaging to do that. Pain management, anti-inflammatory, as good as pethidine or morphine, but without the side effects. Medical expulsive therapy has been controversial in this country, so tamsulosin, but the NICE guidance says, although it's a weak effect, it's cheap, and therefore it's probably worth trying. It only really works for patients with stones in the distal ureter, and so people should not be on it for other things, and particularly if you've got a kidney stone in the kidney, and we see this quite a lot, it definitely has no effect. Don't place stents before shockwave lithotripsy, that's a surgical thing. It's quite a controversial thing on surgical treatments, and basically telling us now that shockwave lithotripsy should be first-line treatment for ureteric and kidney stones. So that should be a mind shift in terms of the way that we treat things, and maybe, like I said, lithotripsy will increase again. Tells us not to put stents after ureteroscopy, and of course that's the bane of life for patients following ureteroscopy, and so increasingly trying not to place stents, but it's also a safe thing to do. Reminds us to do metabolic testing, and also in terms of preventing recurrence, make some pretty basic but sensible guidance, which applies to all of us. So it says consider potassium citrate if you've got a recurrence of stones that are predominantly calcium oxalate. So it's not saying go and do all that complicated metabolic testing I was telling you about. That actually, if you're a recurrent stone former, then actually just give them some potassium citrate and that will reduce their risk. And also just tells us that they should drink 2.5 to 3 litres of water per day, add fresh lemon juice to drinking water, avoid carbonated drinks, low salt diet, maximum 6 grams per day, and don't restrict calcium. So that's the nice guidance on stone prevention. And then finally, the GIRF document, which is mainly to do with us and surgery, but actually gives this concept now for us as having this acute stone service. And it's what it tells us to do a CT scan. What it wants to do is to try and get away from patients being admitted and just having a stent put in and then going on to waiting lists, which depends where you live in the country, can take months to come back for your definitive treatment. But actually, the acute stone team should be looking to offer shockwave lithotripsy or ureteroscopy as primary treatment. So if you've got an 8mm stone in your ureter, you shouldn't just be stented unless you've got kidney failure or sepsis. You should have primary treatment with shockwave lithotripsy or ureteroscopy. And in fact, GIRF say this should be done within 48 hours of that decision, which is almost impossible to meet, as you'll understand, in the NHS. This is the lithotripsy at London Bridge, just to show you that. We've only had that for since April last year. Our results are really, really good, higher than 90%. That will be due to patient selection, I think, and I only put patients forward for it who I think are going to succeed. But of course, that's a good thing, isn't it, that success rates are so high. Another beautiful picture of stones. These are cystine stones, and there are my contact email details if you've got any questions for me. But obviously, happy to take any questions now. Thank you very much for listening.
Thank you, Mr. Bolster, for that. And thank you again for both our consultants for the excellent talks. We are now going to take questions. So if anybody has had or has any questions, please put them in the chat. I'll just have to check now. Just 1 minute.
If there aren't any, I'll ask one. Kamal, I'll ask one.
While we wait.
Jonathan, can you hear me?
Yeah, perfectly.
I saw you mentioned finasteride and 5-ARIs in your algorithms for treatment. I just wondered, I mean, obviously, I see patients with prostate issues, LUTs. I commonly use alpha blockers. I think it seems to be much harder to prescribe things like finasteride now. So although we know it may work well for sort of larger, fleshy prostate, actually the side effects related to it and concerns about, that's publicized, at least in the press, about sexual side effects and post-finasteride withdrawal syndrome and very rare suicidal things. Where do you think that fits in now? Do you do that a lot, or do you agree that's increasingly difficult to recommend to patients?
Yeah, I think it's recently come to the fore that there is some cognitive or mental side effects, and we have to counsel patients on it. I think it has a role in my practice, particularly with the large prostates that may have hematuria, bleeding. We see patients respond to it, but I think it's all about risk-benefit ratio. And I think finasteride, doesn't have a really efficacy in the short term. So if it's a short-term fix, if somebody with bleeding and hematuria, they need surgery, then you may probably avoid finasteride. I'm going to sit on the fence really because, we've been using it for years and I've followed patients for years and they've never had side effects. So I think we need to see more data from other institutions. But I think in primary care, it's something they need to be aware of, that they are seeing some patients with suicidal ideation and other cognitive side effects of finasteride. They should be aware of this. And if there's any kind of question marks, do get in touch.
Thank you. We've got Antonia. They've got their hand up, so I don't know, Alex, if they can be unmuted or. Hi there, Antonia. Can you hear us?
I can hear you very well. Thank you very much. Thank you very much, both. It's been very interesting from point of view of GP to be brought a bit up to date on how you guys reason around our patients. A lot of my work is mostly occupational health based, and I deal a lot with people working away from readily available medical care, offshore, abroad, kind of thing. So one of the most frequent questions is regarding kidney stones, which are asymptomatic. To everyone's hopefully breath of reassurance, we're soon going to get rid of doing routine urine samples to just detect blood in the urine, and then it ends up to investigation. Hey ho, we discover stone, which, yeah, has probably been there forever. The question I need to answer to the employers is what is the risk for these people to actually develop complications. So for the smaller stones, thank you very much. I took a screenshot of your risk assessment, so that is fine. However, in circumstances where someone has had an episode of colic, and even if the stone is resolved, if dehydration was not the immediate reason for them having a stone, is there any way to quantify their risk? I know the hard questions, yes.
Yeah, no, I like hard questions. It's good. Yeah, there's a lot to that question, isn't there? So, I mean, so just in terms of size, you're right. Small stones, most likely to pass if they were to move. Also, the most difficult to treat if you've got that slide I showed where you got multiple 2mm stones. That's a very unsatisfactory ureteroscopy to do. And the problem getting rid of those, it doesn't mean a 2mm stone doesn't reappear within a year or two. And so I try to push patients away from having those treatments. I think for larger stones, I tend to recommend treatment if it's 6mm or greater, and that's based on the fact that that's unlikely to pass if it were to move. Of course, people can pass those stones, but just statistically, that becomes you're more likely to run into trouble with it. I think when you see people in private practice, it is a bit different. A lot of them work in the city. They do a lot of frequent flying. They really don't want to have their lifestyle interrupted or have a problem while in the air or abroad. So sometimes that leads us to treatment. In terms of what you can do, we get a few pilots who can't fly with any stones in their kidney at all, and the CAA have very clear guidance on that, so they end up needing treatment even for small things. So if they've got anything in the calyx, they're grounded and don't get clearance. And I'm also advisor to the Maritime and Coast Guard Agency, and I've been trying to loosen their guidance with them over the last 5 years, which has been a bit of a journey, and it's quite tricky. But they used to say if you've ever had a stone, you can never work far coastal ever again, which I think is 100.
Sounds a bit, yeah.
120 nautical miles off coast, I think, far coastal. So we tried to slacken that a little bit, and we tried to introduce during the urine testing actually the metabolic testing as a way of stratifying that risk, and that actually if you don't have any underlying metabolic abnormality and you've only got a small thing in your kidney, or you've had a stone and you haven't got any other stones, but what's your risk? Then actually your risk is you've got a group of patients who are quite low risk in that situation. But there's no right or wrong answer to this, and the pushback has been from a lot of providers, because as you say, this is often with people who are abroad, that they can't do those tests where they are. And we even suggested ultrasound, I think it was every 2 years or something. And even that became somehow difficult to do. And of course, ultrasound is very user dependent, and you can get reports that say different things. So there isn't any easy answer to this, I'm afraid. But I think, yeah, I think potentially if you want to stratify them, it's stone size or some kind of metabolic testing to know there's nothing underlying it. And then obviously get the dietary bits right, so that really does reduce their risk. And they need to know that's important if they want to be able to work.
Thank you very much. And I'm happy with that, even knowing there's no exact answer, just to be able to say, well, we don't really know, but how we reason is like this. It's very useful. Thank you very much.
Thank you.
Thank you. Do we have any other questions before we finish up? Let's see. Be the case. As obviously you see that both consultants have provided their details, and we can share those with you following the session as well. So if you do have any other further questions or patients that you'd like to discuss, feel free to contact them directly, and they're more than happy to answer them. It seems like I don't see there's any other questions, so we will finish up for the session. You will be emailed a survey just in a few or over the coming weeks, so please do complete that, and we'd like to hear any other future talks that you'd like to hear, and then we also will email you your VPD certificate. So again, thank you to both our speakers that provided the talk today, and thank you for all those that attended as well. We appreciate your time, and have a great weekend.
Thank you. Well, thank you, everyone.
Thank you.